At Synapse, we're strong believers in visual learning. That's why we endeavour to transform complicated topics into animated masterpieces tailored for UK medical students. We're proud to present to you your very own virtual lecture room. Tuberculosis, or more commonly known as TB, is one of the most deadly infected diseases in the world. It's thought that 1/3 of the world's population are infected with TB, though the majority of these are latent infections. The World Health Organization estimated that 9 million people developed TB in 2013, and that 1.5 million died from TB, of whom 25% were co-infected with HIV. Mycobacterium tuberculosis is the second most common infectious cause of death in adults, with HIV being the first. Significant strides have been made in the prevention and treatment of TB between 1990 and 2013. Mortality from TB has dropped by 45%. In the UK, TB has an incidence rate of around 1 in 10,000. This is significantly higher in London, where incidence is 3.5 in 10,000. Let's now look at the pathology. To really understand the pathology, we need to look through a microscope. There we go. TB is caused by Mycobacterium and spread via respiratory droplets. Mycobacterium are an aerobic bacteria. Those capable of causing TB in humans are referred to as the Mycobacterium complex. The most commonly discussed organisms are Mycobacterium tuberculosis and Mycobacterium bovis. We're going to focus on Mycobacterium tuberculosis as it's the most common. This type of bacteria is classed as an acid-fast bacilli due to the waxy cell wall from mycolic acid. This means they stain bright red with Ziehl-Neelsen stain. As you can see, this bacteria is rod-shaped. They are also obligate aerobes. This means that they need oxygen to grow. They are also facultative intracellular. This means they can grow outside of the cell, but find it advantageous to be intracellular. Let's now look at how this deadly bacteria gets into the body. Won't be needing this microscope anymore. Instead, let's get a pair of lungs. Although we breathe in all sorts of viruses and bacteria all the time, we have defenses that take care of most of them. For one, air that we breathe in is turbulent in the upper airways and drives moist bacteria against mucus, which is then cleared pretty quickly. Ultimately though, TB can avoid your mucus traps and make its way to the deep airways and alveoli, where we have macrophages which can eat up foreign cells and destroy them. With TB, they recognize foreign proteins on their cell surface and phagocytose them, essentially package them into a space called a phagosome. With most cases, the macrophage then fuses the phagosome with a lysosome, which has hydrolytic enzymes that can pretty much break down any biochemical molecule. TB is tough though, and once inside the macrophage, they produce a protein that inhibits this fusion, which allows the Mycobacterium to survive. It doesn't just survive though, it proliferates and creates a localized infection. At this point, somebody has developed primary tuberculosis, which means they have signs of infection soon after being exposed to TB. Even though it sounds bad, most people at this stage are actually asymptomatic, or maybe have a mild flu-like illness. Now, where did the other bacteria run off to? You can run TB, but you can't hide. Looks like we're not the only ones trying to find them. Ah, here they are. About 3 weeks after initial infection, cell-mediated immunity kicks in. And the immune cells surround the sites of the TB infection and create a granuloma, essentially in an attempt to wall off the bacteria and prevent it from spreading. The tissue inside the middle dies as a result, a process referred to as caseous necrosis, which means cheese-like necrosis, since the dead tissue is soft, white, and looks a bit like a cheese. This area is also known as a Gone focus. TB also gets the nearby hilar lymph nodes, either carried over by immune cells through the lymph or by direct extension of the Gone focus infection, causes cessation there as well. And together, this casating tissue and associated lymph node makes up the characteristic Gone complex. Gone complexes are usually subpleural and occur in the lower lobes of the lungs. This tissue is then encapsulated by the granuloma, undergoes fibrosis, often calcification, and produces scar tissue that can be seen on X-ray. This calcified Gone complex is called a Ranke complex. In some cases, although there are scars left over, the mycobacteria is killed off by the immune system, and that's the end of that. In other cases, even though they were walled off, they remain viable, and are therefore still alive, but they're just dormant. Once the bacteria has reached the primary tuberculosis stage, it has a few different paths it may take. Primary progressive TB is when the primary infection is not suppressed. Latent TB is the outcome in the majority of patients with primary TB, and it's a non-infectious state. Post-primary TB is also termed reactivation TB, and it occurs in patients with latent TB, frequently due to immunocompromising diseases. Active TB can either be primary progressive TB or post-primary TB, with the latter being the most common form. The clinical features of TB depend on the organ system involved. The most common organ affected is the lungs. Primary progressive almost always presents with pulmonary disease. However, post-primary TB can present with extrapulmonary symptoms. Let's focus on pulmonary TB. Start off with common symptoms are cough, fever, shortness of breath, weight loss, hemoptysis, and there can also be symptoms of laryngeal and pharyngeal involvement, such as a hoarse voice. Lymph nodes are the most common extrapulmonary site. Nodes are typically described as enlarged, firm, and non-tender. It most commonly affects the cervical and supraclavicular nodes. Let's now look at miliary TB. Miliary reminds me of military, so I'm going to draw a gun to help us remember. This is the disseminated hematogenous spread of the bacilli. A distinguishing sign is the appearance of millet seeds on a chest X-ray. This almost looks like someone has shot lungs with a gun, as shrapnel has spread across the lungs. Multiple organ failure may develop, and organomegaly may be present. So, these are the common forms of TB. Other extrapulmonary forms can include CNS TB, vertebral TB, and adrenal TB. CNS TB has numerous manifestations, the most common being TB meningitis, which presents with fever, malaise, and headache. Vertebral TB is also known as POTS syndrome, presents with fever, weight loss, and back pain. Neurological deficits are seen in half of the patients, and spinal deformities such as kyphosis is common. Finally, adrenal TB is a leading cause of Addison's disease worldwide. To find out about the diagnosis, let's take a visit to the Synapse labs. The lab technicians are on a break. No wonder it's so clean. They haven't even filled out what tests need to be done to diagnose TB. Let's help them out, shall we? Okay, so the investigations we need to do depends on whether it's active or latent TB. Let's start off by looking at active TB. The first line investigation is a chest X-ray, which almost always presents abnormally. There's fibronodular opacities in the upper lobes with or without cavitation. Secondly, an acid-fast bacilli smear needs to be performed. The result of this would be positive in TB. Then, a full blood count would show a raised white blood count and a low hemoglobin. Finally, a polymerase chain reaction would be used on sputum or any bodily fluid, and it would also be positive. So they're the tests you do for active TB. Let's now look at latent TB. A MAN2 test can be performed which involves an injection of tuberculin and triggers a type 4 sensitivity reaction. However, previous BCG vaccination can alter these results. In this situation, an interferon gamma release assay can be performed. This is typically used after a positive MAN2 test. Well, I think we've made enough of a mess here. Let's hope the technicians don't mind. Moving on to the management of tuberculosis. Let's take a trip down to Synapse Pharmacy. This is Sina, our pharmacist. The management for active and latent TB are different. Let's start off with active TB. This involves a combination of 4 drugs: rifampicin, isoniazid, pyrazinamide, and ethambutol, which is given for the first 2 months, followed by just rifampicin and isoniazid for the following 4 months. Now for the management of latent TB. Either isoniazid is given alone for 6 months, or both rifampicin and isoniazid are given for 3 months. And yes, TB is a notifiable disease, and contact tracing is important. Thank you, Sana. That's the management of TB in a nutshell. Now we've reached the end of the lesson on tuberculosis. On behalf of the team at Synapse, thank you for watching. We look forward to delivering you more lessons in our virtual classroom. See you then!